committee and chairperson for giving this opportunity. So I will be talking about circular anatomy and approaches of anterior cranial fossa from Endonasal perspective. So starting with anatomy, the skull base is divided into three parts, that is anterior cranial fossa, middle cranial fossa, and the posterior cranial fossa. The anterior cranial fossa accommodates the basal cortex of the frontal lobe and olfactory bulbs. This anterior cranial fossa can be approached either from the transcranial route or from endoscopic approaches. Initially, this endoscopic approaches was only limited to the pituitary, but with improved endoscope, improved technique, and with better visualization and illumination, we are now able to reach up to the frontal sinus. So, continuing with the anatomy, this anterior cranial fossa is limited laterally by the sphenoid disc and medially by the sphenoid limbus, and in the center we have special area which give attachment to the fox, and we have the tubuliform plate which has multiple openings through which this olfactory nerve passes. So this is lateral nasal wall. Here you can see the inferior turbinate, middle turbinate, sphenoid sinus, and we have the frontal sinus, and this is the middle orbital cavity. So this is the endoscopic view, in which you can see the anterior cranial fossa. The lateral margin is formed by the lamina fascia. This is also the medial wall of the orbit, and this anterior cranial fossa in the posterior stick, there is a sphenoid bone, and this sphenoid bone it has got a sphenoid sinus. So in the coming slides we will be discussing about the two approaches, that is transplanar approach and transtubuliform approach. So endoscopic endonasal approaches to the anterior fossa require different degree of sinonasal restriction depending upon the location and extension of the human pathology. When the lesion is located in the posterior stick, we plan for transplanar approach. If the tumor is involved the anterior two-thirds of the ACL anterior cranial fossa, then we have to do this transtubuliform approach. So this is endoscopic intrasphenoidal landmark. So here you can see this is the clavus, then we have the sella, then this is optic prominence, this is carotid prominence, then we have limbus sulcus, and this is plenum. So if we are planning for pituitary surgery, then this much of bone exposure is adequate for doing this pituitary surgery. And this is how the bone is gradually removed. Then we are planning for accepted transnasal approaches. So this one is a tuberculum stud, is lateral margin from the medial OCR, and this is also a transition from between the supracrinoid and paracrinoid artery. Once you remove this tuberculum stud, then we are able to see this superior intertuberous sinus. So the next step represents the further removal of the bone to expose the plenum dura. If we are planning for extended transplanar approach. So when you remove the dura or the plenum area, chiasmatic sulcus, then these are the sectors that are visual. These are optic nerve, chiasm, then here the pituitary gland, and then this is superficial superficial artery which supply the chiasm as well as the pituitary stalk. When the dura or the plenum is removed, then these are the structures that are visual. Here we can see the bilateral AC with the ACOM, gyrus rectus, and as well as the optic chiasm and optic nerve. So we'll see some surgical video. First is the pituitary microadenoma. So this was 40-year-old female. She presented with a bilateral decreased vision. So this is typically a double-shaped pituitary tumor. So first the endoscope is introduced along the base of this nasal floor. Here we can see the septum, middle turbinate, and above we have the sphenoid sinus. This sphenoid sinus is typically located around 1.5 to 2 cm around this corner. So when we have introduced the endoscope on the opposite side, there is a septal spur. So this was not a good site to harvest this mesoseptal flap. So from the right side only, we are harvesting this mesoseptal flap. First cut is made along the floor of the mesoseptal floor. And the length of this mesoseptal flap depends upon the type of surgery that we do. The first cut, after the first cut, then second cut is made, the upper cut is made. This should be at least 2 cm below this roof because they contain the olfactory bulb. Once the anterior and the superior and inferior cuts are made, then the anterior cuts are made, and then this flap is gradually raised and it is reflected in the fossa. After that, the posterior septal stone is done. Here we can see the bilateral sphenoid sinus opening along with the keel of the humor. As we can see, this sphenoid sinus are multiseptated. This septation should be gradually filled with a diamond drill because sometimes these septations may have attachment with the carotid artery. So if you are removed with a rongeur, there is a chance of injury to the ICL. So once all the septors are drilled, here we can have the frontal landmark, that is clivus sella optic nerve this prominence. So for pituitary, this much of bone is sufficient. So with the diamond drill, first we will drill the cell floor, then with the correction rongeur, we are taking out the rest of the bone. So this is after complete cellular bone removal. Once done, then we populate the dura and we cut the dura in the fashion and we remove the tumor. So once after tumor removal, then hemostasis is done and we place the mesoseptal flap. While keeping the flap, you should keep in mind that there should be no twist or anything in this flap. So this is the posterior scan showing the complete excision. Next, this is craniopharyngioma. This is solid cystic lesion in the cerebrosupracision region. So again, the basic steps are same. We have to introduce the endoscope along the floor and we have to identify the structure corona. Here you can see the sphenoid sinus and the middle turbinate. Again here with the same steps, we are raising this flap, mesoseptal flap. In this case, I have used bone cusa to remove the cellular floor. The advantage that I got is that this bone that we have removed, it can be used later on for cellular floor reconstruction. So this was the cellular floor that was removed. So again, the dura is opened. The pituitary gland is mobilized down and it is the tumor is punctured. You can see the cyst fluid coming out once it is punctured. So gradually the tumor is removed. And you can see once the tumor is removed, we can see the underlying structure. Here we can see the bilateral ACA with the acorn. Carefully sected from all the vascular structure. So this was a calcified part that was being removed. So once the excision is done, then we have to do the stellar cord reconstruction. Here we have used the abdominal fat graft, followed by glue, then the nasal septal flap, then we have placed the bone that we have to remove. Again we have placed some fat, and then again glue. So this is the post-op scan that was showing a good excision of the lesion. So next, I'll be talking about the some extended approaches like tuberculosis meningioma. So this was 34-year-old female who presented with decreased vision in both the eye. So this was the pre-op MRI that was showing the meningioma. So again the basic steps are same. We are taking the nasal septal flap. Here we have taking a larger flap. Again posterior septal stoma. Then removal of the sphenoid rostrum. Here also the sphenoid sinus was multi-separated, so all the separations were gradually drilled with diamond nerve. So this was anatomy. So this is after complete removal of this disease. So we can see that here, this is the clivus, this is the sella, and this is the sulcus, this is the plenum area. Here is the optic nerve prominence. So if we are planning for extended approach, we have to remove this sella along with this plenum area. So first we will drill the cell floor, and gradually we take out the bone of the plenum and this tuberculous area with the rongers. So here we are removing the bone in the plenum area. So you can see in the extended approach, this much exposure is done. So here we are coagulating this intercavernous superior intercavernous sinus and cutting it, and we are opening the dura, and we are taking the tumor out. Once we take out the tumor, we can see the underlying structures. So this is the postal scan that is showing a good section. So this was another case that is showing a giant pituitary which was also extending to the plenum area. So the one is the postal image that was showing a complete excision. Now coming to the transcritiform project, they are indicated for CSF, mucosil, large osteoma, caprosil, meningosil, or sometimes this objective meningioma. So in case of transcritiform approach, this is the exposure that is required internally up to the frontal sinus, posterior to the lemma sphenoidal, and laterally up to the lemma papillaceae. In the midline, we can see a small vessels which are anterior thyroidal artery and the posterior thyroidal artery. So if you are planning for tumor surgery in this area, these vessels need to be calculated for early tumor devascularization. So once this method is defined, then we start drilling the bone, usually from the anterior part near the frontal sinus, and gradually we proceed down to the cranial area. Once it is done, when we reaches near the midline, it is very thick, so we have to do careful drilling. Once it is removed, then in case of tumor, we have to devascularize this dura for early tumor devascularization of the tumor. So I will discuss one case of spontaneous CSF leak. Here you can see the scan. There is a defect in the cuneiform on the left side. So here we are introducing this endoscope along the floor. Here we are doing this unsunectomy, and also the epimyofibrillar node. Once you remove all this thing, then you can see the opening of the medullary sinus as well as the posterior epimyofibrillar cell. We have to move here the middle terminate also. So once it is removed, then we are confirming our this leak site, the neural navigation. So this was the part of the brain that was herniating. So it is being coagulated and pushed back. Then it is plugged with abdominal fat. Then we put some glue. Then we put facial leather, and then again glue.